the standard of 6 milligrams of dexamethasone for up to 10 days, is that the only real steroid option? Does everyone need that, or do we have any evidence for trying something different?
So in our COVID-19 patients, we mainly use dexamethasone, the 6 milligram dose for 10 days. I have seen it used longer in patients that have severe ARDS or are not really responding, and we just want to give them some more time. After the patient has finished their 10 days, if they're still having some wheezing, or maybe they have underlying COPD and that's still exacerbated potentially, we are using some methylprednisolone therapies for that, or even a prednisone taper. However, if you don't have dexamethasone available at your facility, you can use equivalent regimens of methylprednisolone or prednisone that is recommended in the COVID-19 guidelines. But other than that, at our institutions, I haven't seen a whole lot of other steroids being used outside of the dexamethasone therapy.
Yeah. Any experience in it with any of you with higher doses of dexamethasone?
We have not used higher doses than the 6 milligrams. Maybe Maureen or Jeff have experience with that.
Only in the beginning, back in March, April, I think we were just, arbitrarily using big doses. And I've seen different things, but 10 milligrams once, 10 milligrams a couple times a day. And then I think it was scaled back. And we did suffer a lot of VAP, secondary to that, even though I think any dose can increase the risk. But I think everybody's more on the same page now, where if we can get it, it's 6 of Decadron or 30 of methylprednisolone.
Exactly. So back in the beginning, we were using methylprednisolone at relatively high doses, 2 per kilo initial dose, and then 2 to 4 per kilo per day. So pretty high doses, but now the protocols have changed. And since everything in my world is weight-based, it's 0.15 milligram per kilo with a max dose of 6. The only thing, it may not be 10 days, depending upon the trajectory of their illness, because as some of the children are improving more rapidly than we see the adult population. So they may not get the full 10 days.
Right, and that's actually a really important point, that you don't have to continue for 10 days. If the patient improves rapidly, is no longer requiring supplemental oxygen, you can stop early. One of the advantages of dexamethasone is a relatively long half-life, so it kind of has an auto taper, if you will, and can be discontinued when patients improve. There was some interest I've seen in some centers with higher doses. There was a paper that came out very early this year that kind of got, overlooked as a result of COVID, but it was a general ARDS study done in Spain in the Lancet, Dexa ARDS, which used 20 milligrams for 5 days and 10 milligrams for 5 days for a total of 10 days. And although anecdotally, I have seen other clinicians use regimens like that in sort of, shall we say, times of desperation. But that being said, I don't think there's any real evidence supporting superior to that over the 6 milligram dosing.